It's terrific to be here. I've been with the Better Medicare Alliance from the beginning. I'm Mark Fendrick, a general internist, and I direct the Center for Value-Based Insurance Design at the University of Michigan. And having seen patients for over 30 years, and I was telling Mary Beth, I thank you for the kind introduction. I was a patient for the first time, having open heart surgery in June, and it provided a perspective that I never really had before, but I thought I had in seeing patients across the table for me. So it's been, quite a journey, and I think we're all here today, first day of open enrollment. I'm actually Medicare eligible now, so it's meaningful for me. But I wanted to say, as we kind of kick off this day, which is going to be very intense, is that, in my opinion, there's never been a better time to be a patient or a clinician, right? I think it's extraordinarily important for us to realize what we can do in healthcare, and having experienced an amazing experience for me as a patient, and what we do in healthcare, there's a great divide. And if we could all come together, the multiple constituents here, right, that we could do better for our patients. And as Mary Beth knows, and some of you, I spend a lot of time in Washington. And when most of you get to meet a policymaker, many of them will be here today, or people who are working in administration, they ask you who you represent. And I think one of the reasons why I keep coming back after all these decades is I tell people that I represent patients. I've worked with everyone from Kaiser to Pfizer. I'm willing to work with all constituents, certainly in many in the MA space. But if we could really talk about how to put patients first, I think we would be better off. And I think our three panelists have great expertise and experience in this regard, particularly around moving from volume to value. In the value-based insurance design area, I focus primarily around patient-centered initiatives, but most of the conversations about Medicare Advantage now in the policy space is provider-facing or payment reforms. And I'm very, very lucky to be joined by Stephen, Jenni, and Joe today, who will give their perspectives, a strategy officer, an innovator, and a clinician medical director who could kind of tell us how we might be able to incrementally move forward to spend our dollars better, and most importantly, improve the individual and population health of our most vulnerable population, those being Medicare Advantage beneficiaries. Stephen?
Yeah, good morning, everyone. Great to see folks. The healthcare system is obviously not working great, but it does amazing things. As Mark, survivor open heart.
How do I look? Right? Do I look okay?
You look great. But this is a space that I'm really interested in talking about today. I'm with ChenMed. I'm the Chief Strategy Officer. Been here over 8 years. And ChenMed is a chain of medical clinics, so 111 of them across 12 states, 23 major metropolitan areas. And all we do is take care of seniors in Medicare Advantage. All we do is do that through full risk. So everything is value. I don't even love the word value-based care. Full financial risk, I think, is a real differentiator versus quote-unquote value-based care, because that's been used in so many ways. And we can, I think, talk about that. But what we do is really take care of a demographic that's left behind, right? There's folks in this country whose life expectancies are in the 50s or 60s, and the average is in the 70s. The people in this room, your life expectancy is probably going to be well in the 80s, right? And so we have this huge divide, and it's about access, and it's about the right kind of care, the preventive care, and how is that made possible? And so, this is a really great opportunity to talk about the ways in which that can be done. I think Medicare Advantage is the best vehicle we have in America to do it. But there's a difference between Medicare Advantage and Medicare Advantage done right, and hopefully that's what we'll get to talk about that a bit today. How we really make it work for providers, for patients, for payers, for the taxpayer. So there really is a sort of quadruple win in there. It's double win, I guess. So anyway, look forward to talking about that, and how ChenMed works, how Medicare Advantage and being in a full risk arrangement really opens the doors to create that win across the board. So pleased to be here.
All right, thanks. Hi, I'm Jenni. Excited to be here today. One of the things that really is going to be important for successful Medicare Advantage is really bridging the payer-provider gap in using technology to be able to do that, especially as we look at pushing the patient towards the center of care. On top of working for Vynyl Health and creating the software platform I designed called Profile, I'm also the Value-Based Healthcare Program Director for Boise State University. And what we did is I reached out to what I now call my 80 closest global healthcare leaders and said, help me build a master's degree program to truly teach healthcare transformation. And lo and behold, it was through the creation of that program that the idea for Profile was launched. And over the 5 years where I reached out to the experts like Gordon Chen to teach my lecture on healthcare transformation and Sachin Jain to teach my lecture on MA plans, I could really hear and listen to, we all know Medicare Advantage is by far the best way that we should be delivering Medicare. It's better for our seniors, it's more complete care, it's more comprehensive. But the way we've structured kind of the risk assessment has been less than optimal. I have, like I said, I have CEOs of Medicare Advantage plans that said, if only I could get my providers to do their annual wellness visits and really look at accurately documenting, accurately reflecting the risk of their patients, we could understand how we could start looking at leveraging wellness and prevention programs. And then I would hear from the providers who would be teaching my students and saying, gosh, as it is, I'm expected to see 18, 19 patients a day. How can you expect me to do an annual wellness visit that on the average takes at least 45 minutes to complete to actually sit down and discover these? And so, I'm here on the panel today to say, here's where technology can help do this. How can we start involving patients using patient-directed and centered risk assessment and then simultaneously create stratified risk reports that are given to both payers and providers so that they both get the accurate reflection of where their patients are? What can we do to appropriately give the resources to our providers to produce those best outcomes and really align the goals and incentivizations of patient-directed care, that when we know the collaborative goal is improving patient outcomes, we can allocate resources, we can definitely look at cost containment strategy more effectively, but more importantly, we put the patients back in the driver's seat and allow them to better their own health and work with their primary care providers to reach their maximum output. In my opinion, PCP should get paid more than electrocardiologists, right? They are truly the success mechanism if we're going to make value-based healthcare work. And I think at that, it's perfect timing to turn it over to you.
Yeah, I'm all about getting paid more, so that's fine, as it works for me. So good morning, everybody, and thanks for having me here. So I'm Joe Allen. I'm a family physician, and I do mean that. I'm a family physician. I still see patients 3 days a week, and I get the opportunity to be a medical director with our systems partnership with Agilon. It's Premier Senior Health Connect. We are a hospital-based system. We partner with a group called Agilon that is a risk-based, value-based care entity that is kind of an anomaly. You guys may not hear that often, where we have several hospitals, we have a multi-specialty group, we have 200 primary care providers, and we decided, hey, we're going to take this full risk initiative, which is interesting. When I was hired on as a physician with this system, I was brought in to feed the system. Send more patients to the hospital, send more patients to cardiology. I want my EP guys busy, keep those beds full. And this changes that dynamic. For me as a primary care physician, that's the future of healthcare. I'm doing this. I got into that work because I was told that we want to look for a way to put primary care at the center of the healthcare universe, and that's the way you do it. I don't need the hospital to be the center. I love the hospital. They need to be there. There are sick people that need to be seen there. But we don't need to ignore health until those patients end up in the hospital. So for me, this value-based care has been re-energizing. It has helped me kind of see the light at the end of the tunnel, if you will. I know you said 18 to 20 patients a day. Many of our providers are seeing 30, 35 a day. I don't know how you see 35 patients a day and provide high-quality health care. There are some amazing individuals that can do it, but a lot of us need a little more time. We want to build those relationships with our patients, and this type of endeavor allows us to do that. which is quite exciting for me. It also helps me recruit into primary care. So what's one of our kind of vacuums right now is getting young folks interested in primary care. We don't have enough young physicians going into that, and something like this really starts to get them thinking differently about that, and maybe they reconsider wanting to go and be a cardiologist or what have you. We need plenty of them, but we don't need as many as what we have now. And we need more primary care and more good people in primary care to drive those health outcomes for patients and kind of reinvest in our patients' health. So looking forward to the rest of the discussion.
Yeah, Joe, so I'm going to build on that for a second. So we have to deal with a whole bunch of constituencies, certainly in your life. You have, maybe we'll put patients first. You have to think about provider satisfaction and burnout. We obviously have third-party administrators and health plans. All of you talked a bit about full risk. And I'm just curious if you could start about how the arrangements that you're in, how you think they benefit patients, and by benefiting patients, which in my experience is giving them more attention and high touch, actually makes it harder for you to see the number of patients that your administrators might be telling you that would optimize the revenue for the practice. So I'm just trying, these are all fine line things, but you have a lot of experience in this regard, and I know that you're here because you're making it work. And we'll get to you, Stephen, of course, on doing it right and the idea of are clinicians buying into this idea of full risk moving forward? But Joe, you could start.
It's a great question. I would say that by and large, yes, clinicians have bought into this. If you're going to come in and tell one of our primary care docs that they are going to have to see fewer patients, they get to spend more time with their patients, they're going to see their patients that require the most attention. I can tell you that there is in a world that we live in currently, many of my colleagues will schedule diabetics that are well controlled every 3 months because that's what we're supposed to do. And we see them, and they come in, and I get to bill for that, but I don't do anything. They're fine. But that lady with heart failure that needs to have that touch point every 2 weeks can't get in. And I can't monitor her weight. I can't treat her appropriately. So this allows us to do that. Some of the things that impacts patient, I'll highlight a couple things. One is provider satisfaction. I think you touched on that with burnout. Provider satisfaction gets much higher when I can sit down and talk to her. I go into primary care because I like continuity of care. I like to be a part of the patient's family, for lack of a better term. I'm in the community with them, and that's enjoyable. That's why I like doing what I do. That allows you to leverage that relationship to get the behavior you need, right? So I need this patient to change their behavior, lifestyle modifications, whatever that may be, and you can leverage that with a relationship. If I go in and I don't know this person, say, you need to eat better, yeah, whatever, thanks, and they're out the door. But if I've seen them for 5 years, 10 years, and we say, hey, we really need to talk about your diet. How can I help you get healthier? You need to keep the grandkids around. They want to see you be here. We can talk, that we can have a better discussion of that. Other things that we do that are explicitly highlighted within our partnership in the value-based care world are things that we can do outside of that. So we get paid to take care of the patient. We get paid to invest in the patient and prevent horrible outcomes later. One of those things that we've done are some of our clinical programs. I'll highlight a palliative care program. We actually call it our advanced illness management program. For those patients that are not quite at hospice, but we know they're sick, we know they're probably limited lifespan, maybe a year or so. Those are the folks that end up going into the hospital multiple times. How do we prevent that? How do we make their quality of life better? We're not going to extend life maybe, but we can make their quality much better. This program allows us to kind of have touch points in the home, keep them in the home, have clinical access to providers in their house where they really want to be. Nobody wants to be in the hospital. And so we're allowed to do that with this. We can fund those programs because of programs like Medicare Advantage and value-based programs. And it allows us to keep them there, higher patient satisfaction, higher family satisfaction, higher provider satisfaction. Talk about the quadruple win. There's several of those in these programs. And so we're allowed to invest in those types of things, which is phenomenal. From my standpoint, I'm very happy with that. And I have my patients that have gone through that. Yes, some of them have passed away, but they had a much better outcome as they passed through that program rather than what we did before, where it was the hospital, ECF, hospital, maybe hospice eventually. And this helps bridge that. So I think a really good example of some of that investment into making patients' lives better. There are multiple other ones, but I'll cede my time.
Thanks, Joe. Stephen, so doing it right in Medicare Advantage.
Yeah. I think one of the big themes is we have to make it easier to do it right. And we we have to understand and just admit the fact that, it's the old saying, it's awfully hard to get a person to change what they're doing if their income depends on them doing the opposite or whatever. I'm paraphrasing. I think Upton Sinclair maybe somebody. But look, here's a story recently at ChenMed. So there's a woman recently became homeless. She's got these health issues. She's now lacking the ability to do hygiene, manage her diabetic issues, et cetera, right? What would happen in a fee-for-service world? Whether we're talking about traditional Medicare or Medicare Advantage, if the PCP is paid fee-for-service, and if nobody's accountable for that, maybe the health plan's accountable, but the health plan is a health plan. They're not a care provider. Now, some of them own care providers, that's a different story. But what would happen with that patient? Nothing really. At ChenMed, this is literally a story just shared around our company because we try to celebrate these things. A farm tech realized the issue and was like, gosh, this woman's homeless. What can we do? Figured out with these other staff members, how do we get them some clean socks? How do we get them whatever? Got a case manager, got the case manager to help them find housing, all this sort of stuff. Because otherwise, the woman was going to the hospital for respite. The woman was going, right? That's what costs us in full financial risk. It's not, oh my gosh, could we see here and can we get a higher E&M code? No, money is out of what happens to her health and well-being. And if she's living in a hospital essentially every other day, that's expensive. So then we also say, hey, we're here. We want you to come in every single day. I don't need to take a 20-minute PCP slot to consume the 18 or the 35 or how many number is the right number for different practices, but I want you to come here. That's what happens when you have full financial risk, because then you're saying, I care about the human being. I care about that woman. I care about how she does. And then when I multiply that by her times the other hundreds of people on a PCP's panel, because the PCP says, this is my family, this is my group of people that I'm responsible for. And then you multiply that by hundreds of PCPs. Now you have thousands and hundreds of thousands of people for whom we can truly transform care. That simply cannot happen in a fee-for-service arrangement. And it's almost, well, I mean, it could happen, but it's very unlikely to happen in an upside-only arrangement. You can say, oh, well, if I did this, maybe I'll get some benefit against some benchmark. It's really hard to figure out what the benchmark is, and who knows in the future. That's what's unlocked. And the problem is, it's just really hard in America to have people take full financial risk, because you have to be big, you have to be sophisticated, you have to know how to deal with the data, all this overhead. And so you see fewer and fewer independent providers doing this, and they get consumed. And I think the opportunity in Medicare Advantage is we have health plans, we have enablers like the Agilons of the world, we have policymakers that can do things to reshift the potential for how to help independent providers do the right thing, the kinds of things Joe's saying that the providers want to do anyway. They just can't. And right now, it's risky. Why would I take a guaranteed knowledge of if I can churn through 25, 30 patients a day, I know how much I get paid per time, I know what my income is going to be at the end of the year, now I'm going to take this leap and take risk, and then all this stuff happens, and I don't know. No, we have to make that more attractive. And I think we can in the arrangement that we have. We just have to fix things about the way that some of the risk adjustment works, the way that some of the relationships between payers and providers work, the way some of the STARS programs works. And annual wellness visit's a great example. I don't want an annual wellness visit. I want a longitudinal relationship, and over a year, I will cover everything. And what matters now is whatever may matter to that patient. So that's the model that we're able to do. It's just we have to make it easier for others to do it. It's harder for us to do it than it was 5 years ago for us to do it. And a lot of people who have tried have already gone bankrupt, failed, whatever, and that's what we need to try to solve.
So Mary Beth and I agree that it should be easy, not hard, to do these things, but we've been doing it long enough to realize that nothing's easy. So Jenni, I'll call you. So we'll hear later we're so lucky to have Dr. Oz here, and he'll speak in platitudes about how this administration actually feels that one of the answers to do it right is technology. Now, I know that's a broad term to you, but my kids think I'm artificially intelligent, so I can't even talk about AI. But some of the things that you're talking about, Stephen, this is old-fashioned technology. Joe and I have been doing telemedicine. I was doing it before COVID, but these are things in place. Hospital at home is viewed, in my opinion, as technology. But I'm going to, as a national expert in this space, Jenni, You could take as long as you want to kind of either get us excited or fearful, like some of these new AI movies, about what technology has in store for us to make it better for patients, hopefully, make it easier, not harder for clinicians, which most of us would argue there's two sides of that coin, but also the concerns about what technology might do to healthcare spending. And I know that's a lot. You could pick a few of those where your platform fits in. That's entirely up to you. But take us through your thoughts.
Perfect, thank you. So, first and foremost, especially as we're looking at the Medicare Advantage population and our senior population, I want to start off thinking about technology with number one, dispelling the number one myth, which is our seniors are scared of technology. Our seniors don't want technology. That's just not true. All you have to do is get on Facebook, right? The whole reason I keep my Facebook account active is because all of my dad's Coast Guard classmates are my friends on Facebook, and they post daily. And if I don't respond to them, they will call my mother, is Jenni okay, right? Like, what is going on? Prior to my role at Boise State, I was Senior Director of National Accounts for a telehealth software company. And one of our greatest advocates for utilizing technology for seniors was over 100 years old. He had to be in a skilled nursing facility, not living with his wife, because he had to take daily COPD treatments that they felt he could not do on his own. We set him up with video technology in which he had daily video visits with his nurse. And lo and behold, he was able to not only do remote patient monitoring programs, but self-administer medications and move back home where he wanted to be. And at 100 years old, he would joke, like, if I can do this, anybody could do this. And what I can say with technology is, if you are giving the gift of increased health accessibility, ease of use, every single patient will benefit from utilizing technology. They are not scared of it. And so, that's just probably the brink of the iceberg. But how can we use technology? It's by increasing smarter, not harder workflow, right? We all know that the administrative burden right now is really what's driving people away from healthcare. I'm a nurse by background, right? And so never in my schooling was I ever taught, gosh, not only do you have to take care of patients, but you have to look at cost containment strategy. You have to look at learning an electronic health record. But if we can utilize technology to make things easier, reduce workforce burden, it's definitely going to be adopted. And you talked about my platform. The other thing that technology can do is it can align goals and communications, right? So when I was designing Profile, it simultaneously gives stratified risk reporting, stratified patient reportings to providers and payers at the exact same time, so that they get the knowledge of their patients and they can look more like they're working together. But we have the availability of multimodal communication. If it's texting, if it's getting on a computer, it's all of this. And we can leverage AI to take away a lot of that administrative burden. We have pages and pages of data that is just not available for people. And so how can we utilize technology for concise reporting, for concise data aggregation? And then, one of the biggest, like I said, this is such a huge topic to cover in probably like my 6-minute time zone. But interoperability is huge. So as a vendor, one of the things is, for those of you that know the company called No2, right? It is one of the federally qualified QHINs. Luckily for me, they're also one of my guest lecturers, and I called and I said, hey, can we build a vendor platform directly into this QHIN so I don't have to worry about integration into all of the electronic health records? And they're like, why, yes, we can. And guess what? All of a sudden now, we can take technologies in different systems and get them out to payers and providers to really bridge that gap, so that we're looking at more coordinated care and less siloed care. So I agree with all of you, and I tell our students, I tell everyone I talk to, I think we are entering into the most exciting time ever in healthcare. I think healthcare today is not what it's going to look like 2 years from now or 3 years from now. And I think if we start learning to embrace technology to make ourselves more efficient, that's only going to help, and it's going to help ease the burden of the parts that are driving providers away, which is that administrative side of things.
Yeah, so I appreciate that. And so I'm certainly obsessed with interoperability. I'm also obsessed with continuity of care, which I'll talk to the two gentlemen about. But Stephen, you mentioned once, maybe twice, the importance of independent practices. So, for those of us who are looking at the healthcare landscape at a very high level, we're seeing this arms race of consolidation on both the provider side and the payer side. So can you tell us a little bit more about why independence is so important in terms of how you think we could do MA right?
Yeah. So I think that when you think about the healthcare system, the big powers that be are basically big pharma, big hospitals, and big insurance companies, right? And then if you want to get into the provider space, as Joe said, as you guys said, brain surgeon, heart surgeon, all this stuff, right? The lowly family practice, primary care. No, we got to flip that upside down. And so independent practices, these are places that I think people want to go into. We have this issue about, we have a provider shortage. I don't know if I want to be that. There's so many studies saying, doctors tell their children, don't become a doctor like me, right? And so we have to change that. And I think what they want is an environment in which they have some control over their practice and doing the things that are right for them. And so I think that's the place where you can create a balance for the patients to have choice, right? Especially this administration talks about competitive markets and choice, right? We want there to be choice about where you can get care. You want to get care in places that are not tied to other sort of incentive schemes. The simple fact is hospital-led ACOs have done worse than physician-led ACOs. You have any guesses why? We do. Right? The hospital benefits from the patient being acutely sick and being in the hospital, right? And so you want some independence. Then the health plan. You want to make sure that they are giving patients a choice in the network of providers that they can go to. You want the patients to be able to choose that. You want the sort of a fairness and an equity in the way that the payer is paying. And so you don't want this shell game of, oh, well, I need this, so I'm just going to pay more to my owned provider asset versus this and the independent. So we just want this sort of level playing field. I think it ends up benefiting everyone if you have that. And tying it a little bit back to the technology comment. So hopefully technology can be a sort of democratizing force in that. What has happened in healthcare is because it has become so administratively complex, the only way to survive is let me join up. Let me consolidate so I can fight the bigger health plan or fight the bigger whatever. And so who buys up practices? Health plans, private equity, and hospitals. I'm sorry, who buys up the doctors? Those three entities, right? And so because these doctors are like, how can I handle this? But if technology, if AI and all these things can make it easier to do the right things, then hopefully that's an opportunity for independent practices to remain independent rather than say the only way I can survive is to get under the umbrella of somebody big who can make all these multi-million-dollar investments in technology. And so, we'll see where technology goes. It's ultimately really an accelerant, right? Technology generally accelerates. And so my big fear with technology is I don't want it to accelerate fee-for-service. I want it you got to get people in the right incentive structure and then figure out how to use technology to accelerate success in that arena.
Yeah, so Joe, if you could build on that, and I think a lot about this continuity issue. Mm-hmm. We did a survey of Medicare beneficiaries about a year ago, and a substantial minority of them were talking about getting healthcare services, medications outside of our practices through these one-off vendors who want to deal with this condition, that condition. Is there a way you have this really ideal patient-centered model Are you putting any guardrails in place for this regard, or how do you kind of ensure not only continuity, but you have the complexity fully covered in terms of what your patients, particularly those with multiple comorbidities, might need or use?
Yeah, it's great. I think when you look into those things, you start to consider what these complicated patients require. It's a competitive market, as we just talked about. There is little niches here and there, and companies that want to kind of elbow their way in different places, which is fine. If they can do it better, I want to talk to them. I want to figure it out. But I think the best way to do it is to hold us accountable to outcomes and with value-based care. My patients, I would agree with you, Mark. What drives me is continuity of care. What drives my patients is continuity of care. You build those relationships over time. I think generationally, we may have lost some of that. I think about the small town doc in Ohio where I grew up, that he delivered babies. His house was right across the street from his office, so he was never closed. His wife said he never ate dinner at a full meal while it was warm. He always got interrupted. Patients would stop in, and he took care of them all. And if that model in that time frame, if you take that model and leverage technology and technological resources, you can do some really, really, really interesting things with patients. I think back when I started in practice, I was still going to the hospital. I didn't deliver babies, but I was seeing my babies in the hospital. That kind of touch point with the patient in the hospital, knowing what's going on, I may not have been the best hospitalist, but I was the best person to know what their social structure was at home. I was the best person to understand their family dynamics and maybe what pressures they have. And so I think their outcomes were better. I don't have any data to prove that, but I like to think that. And I think that those types of touch points are what we need moving forward. That continuity of care is so important. I'll take a real quick minute to I tell my students about situations with patients, and I'll use something very simple like asthma. In today's environment with asthma, my patients, if they're sick every month and they have an exacerbation every month, they come in, they get a breathing treatment, they do better, I put them on a steroid, they go home, and next month they do the same thing. At the end of the year, I saw them 12 times. I did 12 little procedures on them with the breathing treatment. I coded that visit 12 times, so I made a fair amount of money. In a value-based proposition, that doesn't work. That is not good. I should be taking better care of them. I should start talking to them about maybe controller medications, or maybe we sit down and have a conversation and you discover that they don't have an air conditioner. Well, shoot, I'm going to buy them an air conditioner so they don't have these exacerbations. By the end of the year, I'm seeing them twice. They're doing better. I'm happier. Everybody wins. And so if you kind of compare and contrast with why our younger folks are shying away from it, why they're joining systems, why they're doing other things and being owned, some of that is the reason why. We're not allowed to do those types of things in these volume-based markets, these volume-based models that a lot of folks are pushed into, and that's what they see out there. So, yeah.
Thanks. So I'm going to ask about how we could work a little bit harder to align incentives between providers and payers, but I'm going to look to you, John. I've neglected my role as moderator. I don't remember whether we're going to have circulating mics or in a few minutes, we're going to hear from you, hopefully, and you can ask the panelists your questions. But so it's raise your hand and circulating mics. Thank you. And so if you, in a minute or two, you'll raise your hand, or you could do it quietly during this next phase, and we'll get the microphone delivered to you. But I think it's extraordinarily interesting to see that you go to meetings like this, and I think everyone has the kumbaya moment around the fact that we want to put patients first. And then the details start arising and the incentives arising. And those of you who know my work, it's been all about incentives. And I think it should be, again, easy, not hard, for a clinician to work with their patient to understand their preferences and deliver the care that they want. Sometimes it's aggressive, sometimes it's not. But seeing now, as things get tighter and the BMA reports continue to show us, patients are being asked to do more, clinicians are being asked to do more, and why I'm such a fan of Medicare Advantage is that's often much, much less than what's happening in traditional Medicare. I like to say Americans don't care about healthcare costs, they care what it costs them. And one of the reasons why I've loved MA since the beginning is patients get more for less. That doesn't make Stephen's job any easier, or other administrator, or Dr. Oz's job easier about who ultimately pays for care. But kind of putting the patient first is very important. And what I'm seeing now is that given what's going on in this space, that it's actually getting harder to deliver on these lofty goals because of the misalignment of incentives. So Jenni, you could start with that, and hopefully others will kind of chime in, because I'm looking for nuggets to take back. Right, and I think many of the audience are looking to take back, like, how can we actually do, doesn't have to be perfect, but a slightly better job to get people all on the same page?
Well, number one, I think these guys have really touched on it. I think that we have to stop allowing for just providers not really getting reimbursed that are not assuming full risk, right? It is so hard for practices to set up processes when there are multi-types of payment systems where they've got a large majority of their patients operating in one sense. I've got another operating in another sense. When you look at aligning incentives and you give the opportunities for payers or providers alike to look at cost containment strategies as the way that they are going to get more, and I hate to use the word profitability in healthcare, that's where we really have to get to, because we have systems right now that are operating under just RVUs, right? So as a provider, you're only getting paid on this hamster wheel. And so to expect the alignment to be the same of a cost containment strategy like a provider, we have to start looking at how can we make it easier for providers to do that. And I will give you a quick example of this, and then I'll turn it over to these guys. But back in my clinical days, like I mentioned earlier, I'm a nurse by background. We had a patient that used to come in to the emergency room all of the time. 2 or 3 nights a week, she would come in for back pain. One night I was really busy. I grab her chart. They always gave me her. I go in there and I'm like, Sally, did you go to the pain clinic today or this week? No. Did you go to physical therapy like we asked? No. Why aren't you doing this? I see you all of this. She turned and she's like, Jenny, I do request you every time I come here, because when I come into the emergency room, you always give me a sandwich, a packet of graham crackers, and a carton of milk. And she goes, I hate to admit this, but sometimes I come here not because my back hurts, but because I'm hungry. And so I called in at 3 a.m, social services. I found out she didn't understand how to apply for food stamps. She didn't understand how to do all of the paperwork. So here I am coming into work the next evening thinking for sure I was going to be in alignment for the DAISY Award, right? I solved this big problem. Instead of getting the DAISY Award, I got reprimanded for calling in social services in the middle of the night for a non-emergent situation. Not only did I take revenue away from the hospital because this patient was coming in 2 or 3 nights a week, but then I incurred excess expense to actually take care of the patient. So until we start aligning the benefits the same for providers and payers, which is how do we get the best care possible while trying to control excess costs, and we start looking at making it so that the only way isn't through an RVU or productivity system, we're never going to get there. So I don't know if that answers your questions or makes it even more difficult.
It's challenging. Joe, how do we make this happen in Eastern Ohio?
It's difficult, but it is happening, right? We're seeing some of that change. My system, the contract I'm currently under is just as you described. It's RVU based. I have a little bit of quality in here. I have some MIPS stuff. I have this and that, these things that align for the system, but it's not enough incentive for some to get us to the point where we go, oh, I disregard the RVU. That's secondary. That's still my primary mode of pay. So many of my colleagues are just focused on that, and if the quality happens, it happens. But if they lose out on it, it doesn't make enough difference. So aligning those incentives is very important. I talk to a lot of folks about those incentives, and I say, like, my providers, my physicians, whenever I onboard a lot of them. So when I'm talking to them about that, I say, look, we're taught not to talk about money, and we come through med school. That's bad. The financial stuff's bad. Don't talk about that. That's not altruistic. But when you align the financial incentives with better care and those move in the same direction, they are incredibly powerful. If I'm doing the right thing for the patient and I get reimbursed for it, hallelujah. That is going to drive behavior for all of us. in all of our physicians and providers, even though they don't like to talk about money, it's probably in their top 5 most important things, right? Family life, time, whatever else you want to throw in there. Some of them, money is number 1, some of it's number 5, but it's in there somewhere. And if we can align those, I think we'll have much better outcomes for our providers and our patients.
We have a question out there? We see a hand up there. Stephen, why don't you that sounds like the ChenMed mission statement, what Joe was just saying.
It does. It does. I mean, I just quickly, as we get this question, I mean, the fact of the matter is full financial risk works better. We have to decide if we agree on that. But the data shows it. CVS recently put out a report that shows it. Humana puts out reports that show it. America's Physician Groups put out reports that show it. In academia, you guys can study it, I don't know, but right. I'm convinced. And I think CMS, has the data on how these payments, how the contracts work with the MA plans. Put out data. I'm willing to bet you that the people in full financial risk get better outcomes at lower costs. And if that's the case, then what we have to do is figure out how do we align people's incentives to get into that, make it more attractive to get into that. We're allocating the resources wrong because we just do it on, can somebody who sees a patient one time and write down an ICD code that maps to an HCC, can that give them credit? No, it needs to be tied to longitudinal care management. Now, if I have this disease and it's being managed, give resources for that. If you're particularly complex and have interactions of multiple diseases, give more resources for that, more so than the current HCC model works. The social factors outside of complexity, give that. Align the health plans. The CMS can't tell health plans how to contract with providers, but it can decide how it contracts with health plans. And so it can say, if you don't have enough of your lives in delegated full financial risk providers, you're going to have these penalties, or I'm going to give you these carrots to do it. I'll give you better network adequacy rules, or I'll help you manage hospital costs better, or I'll give you a STARS bump, whatever it may be. You can align these things, and we have to create a downhill slope into this full financial risk. I think there's a lot of ways to do it if we have conviction that it actually works better, which I obviously do, and I think the data would support.
No, I was feeling conviction here, and I think before we get to the question, historians wonder how did it happen in the UK in the National Health Service, and the quote is, they stuffed their mouths with gold. So, I'm not sure other incentives are how you would get clinicians to abandon fee-for-service, the abomination that it is. But we've been talking about this, Mary Beth, for a very, very long time. Question, please.
Well, it's a couple of comments. First of all, thank you for all you do for the seniors. I feel like they're the most underserved in our country right now, so thank you for that. I will just tell you, in 2013, I became a better agent because I was taking care of my mother. And the very first cut that always happens is advocacy. And thank you for what you did for that patient, because when you walk into a hospital and ask for a geriatric bed and the people don't know what geriatric means, that's a problem. And then number 2, a hospitalist almost cost my mother her life, and a hospitalist saved my mother's life because he was an infectious disease doctor, and UTIs are on the rise because of lack of care, and they're the most underdiagnosed. And I will tell you that one of the best infectious disease doctors had to choose to become a hand surgeon because he wasn't going to be able to pay off his debt. And one of the things that I want to get across to everybody is that communication is key. And insurance agents are the well care. They're the welfare. They're in the home. 90% of the time, they're the biggest advocate for the beneficiary. We've seen that. We've fought for that. We need more people to talk to us so we can tell you all what is going on with these clients, because a lot of them are sitting there with UTIs and they're being told they're crazy. They're being told they're alcoholics. My mother hadn't had a drink in 20 years and was sent to a mental institution. These are the things we're dealing with because we don't have advocacy. Insurance agents, and I'm sure there's plenty in this room, even though today is kickoff of the biggest Super Bowl of the year, but how do we get to a table? How do we get together? How do we talk to hospitalists? How do we fix skilled nursing? It's broken. We've got administrators that are terrified to admit a patient. They go into observation mode and they die.
Yeah,
and then they get sent to hospice. So the question is, how do we get there?
In 2 minutes and 14 seconds. Thank you. We'll all think about that. And you have the whole day to spend networking on this. So I guess what you're just making the point about open communication, alignment of incentives, putting patients first. No, and I think you could track down some of the experts in the room to get some details here. But I want 30 seconds closing remarks from each of you. I will say, for me, I'm continuing to learn. My head is always spinning when I come. Thank you, Mary Beth and your team, for having me. But when you talked about that air conditioner, Joe, you gave me PTSD. Remember that it's MA that has allowed transportation services, food as medicine services, telehealth, long before this became ubiquitous. It was because of this movement that the three of you talk about whole person care that really makes this work. So Joe, Jenny, Steve, I'll talk in that order. Just you have this questioner asking you, how do we make it happen? Give us your high-level thoughts as before we move on to the next session about what you think the key takeaway should be.
Yep. So aligning incentives, making it data transfer easier. So getting data back and forth. Our quality data, it lags. Our attribution lists lag. Being able to seamlessly move that data back and forth and really have everybody be on the same page is really going to be helpful. I think when you look at Medicare Advantage programs, they are an ecosystem. It's not one insurance system. It's
Right.
all these other pieces that we're touching, and we have to think of it that way when we're designing these models. But align the incentives, that will help, and certainly I will see them.
Great. Thanks, Joe.
So I think we get there by becoming a lot more innovative in care delivery. I think when you look at payment models that are full risk and give the resources to providers to care for the patients that in the way that will produce the best outcomes, the example being refrigerators, food, when they have the resources that a full risk PMPM that is not associated with an RVU system, they can provide the solutions that drive the best patient outcomes for the patients that they know through primary care.
And I think to double down on that, the key is these longitudinal relationships. It's the ability to say, how can I try to get a patient with a provider who has the right incentive for their health and well-being? And that does tie back to your point about brokers and everybody. Like, too much is driving churn. Oh, I'm going to go chase this one little benefit, or the broker gets paid to switch this or switch that, right? We have to align that because we want these longitudinal relationships. And what we really need to do is put people into that financial risk bucket and then have the plans want to have a network of full financial risk providers. And the plans have so much resource and capability, they should be able to help, and they need to have an incentive to say, of my network of providers and of the beneficiaries I take care of, at least this many need to be in full financial risk. And so there's carrots and sticks that can be offered to plans that are going to make them shift that balance between how many providers they're simply paying downstream fee for service and how many they're delegating a capitation risk to. The more we get into that, the more then we force ourselves to answer the questions. How do we apply technology? How do we apply different training? How do we get better data flows to actually meet the needs? But it can be done without the technology. People have done risk for decades. Right. We just need to be able to make it easier so people jump into that.
So let's work to align incentives. Joe, Jenny, Steve, thank you all very much. Excellent job.